Hello, my name is Charlene Berkey, Co-Project Director for the South Dakota Palliative Care Network. We are excited to have Michelle Snyders, social worker with Avel eCare Senior Care. Michelle has 30 plus years experience in healthcare and for the last 5 years in the eCare services line. Michelle holds master's certification in hospice and palliative care and advanced palliative care. Plus, she is certified in hospice social work. Michelle will be speaking on advanced care planning, what, why, when, and how.
We're going to start off by talking about what advanced care planning is. In order to talk about what advanced care planning is, we have to talk about what it is not. It is not just a code status conversation. Code status is something that will be established as a result of an advanced care planning conversation, but it is not the sole reason for having the conversation. It is not a regulatory care plan. Patient-centered goals of care will be a natural byproduct of having an advanced care planning conversation, but this is not to replace your regulatory care plan. And it is not a document. A document, as a result of an advanced care planning conversation that you're likely to be able to establish, is a durable power of attorney for healthcare, a living will, or other portable medical orders. But that is not the intent of the conversation. So what is advanced care planning? Advanced care planning is a facilitated conversation between a patient, their healthcare agent, their loved ones, and a medical provider. The goal of this conversation is to reflect on the patient's goals, their values, and their beliefs, and to discuss those goals, values, and beliefs in relation to possible healthcare choices. Once you've done that, then it's important to communicate this plan to all of the others involved in the care of this patient. So why do advanced care planning? So let's take a look at it from the physician side of things. 90% of patients think that talking to their doctor is important, but only 20% have actually done so. This demonstrates that people are not comfortable even bringing up their healthcare wishes with their physician, but they do feel it's important. 89% of healthcare providers think advanced care planning conversations are important, and 75% of doctors say it's their responsibility. Yet, over 50% of the doctors report they are uncomfortable having these conversations. So the chances of them bringing the conversation up is smaller. Physicians tend to overestimate survival, even in patients with known terminal conditions. An example of this is an oncologist I once worked with who, outside of a patient's room, said they had less than a 10% chance of being alive in the next 3 months. Upon going into the room and having a conversation with the patient, that percentage increased from 10% to 30%. The physician had a difficult time sharing an honest opinion with the patient in order for that patient to make some crucial medical decisions. Another reason to do advanced care planning is to make sure that an opportunity has been given to document the person's wishes. Unfortunately, when you take a look at the medical record and the agreements between those documents and end-of-life preferences for patients, they found that there was only 30.2% agreement between those two things. That means that patients that are going into the hospital are getting care that is not consistent with their wishes and what's documented in the healthcare record. For example, they might be a do not resuscitate or do not intubate, but when they're admitted to the hospital, they're listed as a full code. Even worse, those that want to be full code come in and are listed as a do not resuscitate. When documentation exists, clinicians often don't notice it. They don't know where to find it in the medical record. And wishes captured in legal documents are not always translated into actionable medical orders, leaving healthcare providers uncertain about what actions to take in a medical crisis. So if you have a durable power of attorney for healthcare or a living will, it doesn't necessarily mean it has specifics about what is acceptable and unacceptable healthcare practices for you under certain medical situations. They're a legal document and they serve their purpose for that reason, but they really don't help the physicians determine what type of health care to provide. There are financial reasons to do advanced care planning. Having care directed to what the patient wants can help reduce healthcare costs. Studies have shown that when advanced care planning has been completed, anywhere from $11 to $20 million can be saved across the healthcare by providing care that is consistent with what the patient's wishes are. Also, when advanced care planning has been done in nursing homes, we've been able to reduce unnecessary transfers to hospital for unnecessary care from 22% down to 8%. Again, this is demonstrating a more consistent care approach to the patient by understanding what's important. They would prefer to be cared in place rather than to be transferred to the hospital where they face exposure to unnecessary testing and interventions. Another reason for doing advanced care planning, it's just the right thing to do. This is one of my favorite quotes. Providing care without engaging in conversations about end of life care wishes and delivering care inconsistent with patients' stated wishes are on par with medical errors. We would never administer an antibiotic without knowing if that patient had an allergy to it. So it's important that we're providing care that is consistent with what the patient's wishes are. Another quote that I find compelling states, for certain patient populations, advanced care planning is particularly important. The risk of harm is elevated and more apparent in patients with serious illness or older age. As a consequence of their conditions, such patients have an increased risk of death and may also have an increased risk of potentially harmful events such as hospitalizations, loss of capacity, loss of independence, or loss of identity. Failure to conduct appropriate advanced care planning could be considered negligent, resulting in unnecessary suffering and harm for both the residents and the families. This is another example of why advanced care planning is important, and it demonstrates that patients and families do want to have these conversations and do come up with some wonderful outcomes that can be presented. We did a recent project at a nursing facility. We were able to interview 9 patients. Out of those 9, we were able to actually complete 8 goals of care conversations or advanced care planning conversations. The one person who didn't complete the conversation did not want to have the conversation via telehealth, which was completely acceptable, and we did not encourage him to do something he wasn't comfortable doing. But out of those 8 people that we had conversations with, that included the patients when they had capacity or their surrogate decision makers, 7 out of those 8 patients chose to complete a MOST, meaning they met criteria for having medical order for scope of treatment. They had a terminal diagnosis, and we wouldn't be surprised if they passed away in the next 12 months. This allowed them to have patient-centered orders transportable across all domains available to them wherever they were cared for. Also, of those 8, 6 of them requested to have do not hospitalize orders. Their preference was to be cared for at the nursing facility rather than being transferred back and forth to the hospital for care that they didn't want to have. Also, of those 8, 2 of those were actually hospice referrals. By having this conversation, we were able to introduce the support of hospice services much earlier than we would have if we waited till the very end of life. Of the 8 patients, 1 was initially a full code at the time that we had our conversation. After having an explanation of the benefits and burdens of CPR and intubation in a frail elderly person, their loved ones decided to change them from a full code to a no code. And finally, the one person who didn't meet the qualifications for completing a MOST, but did not want to be intubated or resuscitated, was able to complete a Comfort 1, which in the state of South Dakota are transportable medical orders for the EMS personnel to not do CPR and not intubate a patient when they're en route. So when do we do advanced care planning? So advanced care planning in general, for the general population, we turn to the 5Ds as a guide for when to have these conversations and when to complete documents. First is every decade. So if you're a fairly young, fairly healthy person, once you've completed your first power of attorney and jotted down your values, those likely are going to stay pretty stable as long as your health remains stable. So you should pull those out every 10 years and make sure that they still reflect the people that you would want making decisions and that your healthcare hasn't changed. The second D is divorce. If there is a change in your marital status and your spouse is listed as your power of attorney, that's a good time to update your form to make sure that the person that you now want to make your decisions is adequately listed. The third time that you should take a look about advanced care planning is at the time of the death. So if your spouse was listed as your surrogate decision maker on the paperwork, now it's time to think about who else would you want to make those decisions for you, and do they know what your wishes are, what's important, and what your values are. So it's time to have a conversation with that new patient. The fourth time to have a conversation is at the time that you have a new diagnosis, a new illness, a new progressive disease, a new injury. That's a good time to really talk with your family and friends about what's important, what you're willing to go through, and what you're not wanting to go through as you're facing this new diagnosis. And the last D is when there's a decline. So when you have a diagnosis and it continues to progress and you're reaching end stage, that's another time to have a conversation with your loved ones. Your values and wishes may have changed as your illness has gotten worse, and it's time to update them on what the new boundaries are for your care. So how do you take those 5Ds and apply it to your practice? So think about a new patient coming into your facility or into your clinic. That's an excellent time to have your first goals of care or advanced care planning conversation with that patient. By doing that, you normalize the process. You can simply say, Mrs. Jones, this is something I do with all of my new patients. I want to make sure that I'm taking care of you in the way that respects who you are and what's important to you. I will be talking to you throughout the years as things change so that I continue to provide you care that's consistent with your wishes. This also sets expectations for patients, families, and your staff in your clinic as well. Another time to do it with your patients is when you see a change in their condition. If they're coming into you for an exacerbation of COPD, that might be a time to say, you know what, we're going to start you on some consistent oxygen, and this means that your disease is progressing. So let's pull out your advanced directives and make sure that I understand how to take care of you moving forward. Another opportunity to have an updated advanced care planning conversation is if a patient has been recently discharged from the hospital or a skilled nursing facility and they're coming back into the clinic for a visit. Touching base with them about how that hospitalization went, what changes occurred in their health. For example, did they end up in the ICU and they were on a vent? How was that experience for them? Are they willing to do that again? How does that fit with their underlying diagnosis? Assist them with that conversation and help them find out what was important. What did they worry about during that hospital stay? What can you address moving forward? Another time that would be a great opportunity is when you're starting to get calls from family members or their patients. They're concerned about what's happening to them. That's a really good time to pull them into the clinic and have an advanced care planning conversation specific to their worries and concerns. And then annually, you can do this annually because there's no co-payments when advanced care planning is done for Medicare patients on their annual wellness visits. So that's a great time to just say, you know what, this is an opportunity for us. We're going to just take a look at what we talked about last year and make sure there are no changes moving forward. We're going to take a look at a scenario to try to demonstrate the importance of having these advanced care planning conversations. This is a 96-year-old female with a past medical history of dementia, macular degeneration, syncope, GERD, and arthritis. She resides at a nursing home for the last year after transitioning from an assisted living following a fracture. On her initial admission to the facility, she's alert, no incapacitation noted. Her son is involved in her care. He notes that her mental status is up and down, but she was recently able to play board games with him and is fairly conversant. Code status on admission is no code, and it's been that way for quite some time prior to her admission. There have been no goals of care conversations other than the code status conversation. We're going to fast forward now, and that same nursing home resident falls out of bed. She's been declining and having multiple falls lately. She's sustained a skin tear, abrasion, and a hematoma to her forehead and a nosebleed. She's typically more responsive than she is at present. The staff can't reach her son, and due to the change in her mental status and no prior goals of care conversations, she's sent to the emergency room via the ambulance. While at the emergency room, the resident is complaining of knee pain and is somnolent. The physicians are finally able to reach her son, who wants to limit her testings to only emergently necessary tests. He is eager to get her back to a familiar setting, and she is sent back to the facility without any real testing being done. So, what are some of the missed opportunities here? You have a resident who was admitted to the nursing facility needing more care. Right there at admission would have been a great time to talk about her underlying diagnosis of dementia and how she wanted to be cared for as that dementia progressed. So we missed an opportunity for that initial advanced care planning conversation. Had we had that, we might have found out that she and the son wanted to limit the amount of testing that they wanted to have done down the road. Maybe we would have saved a trip to the emergency room. Clearly, at this time, the son has made it clear that he does not want to do that. So now is a really good time to implement some of the other documents we talked about, like a MOST document, a Comfort One document, and perhaps a Do Not Hospitalize order. So we've talked about why to have advanced care planning and when to have advanced care planning. Now we're going to move on to how to do advanced care planning. Advanced care planning conversations use an evidence-based format that can be learned and developed over time. Often these conversations are held by specialty palliative care teams. And these interdisciplinary teams are made up of specially trained physicians, providers, nurses, social workers, chaplains, and pharmacists. And sometimes other disciplines are involved as well. Oftentimes they've completed particular fellowships in palliative care or hold palliative care certifications for their discipline. So what do you do when you don't have a specialty palliative care team? These are some of the evidence-based formats that you can use to have your own advanced care planning conversations. First of all, you want to do a chart review. You want to get to know the patient's condition. Have they had previous goals of care conversations at the hospital, maybe with the palliative care team? If so, what was talked about? What were the goals at that time? And then, does the patient have capacity to make complex medical decisions? You need to know that. If not, you also need to know who the legal surrogate decision maker is. Who is the durable power of attorney for health care? These differ from state to state, so you need to be familiar with each state statute. Also, are there existing documents and what do they say? How old are they? When were they done? Have they ever been revised? They may add useful insight. Just because you find an older document doesn't mean you can't use that information. In fact, I enjoy using older documents because we can clearly state that 10 years ago, before that person had dementia, these were their values and this was what was important to them. Having known what they have now, how would that information apply to their current situation? And then consider using a values clarification worksheet to complete prior to having the conversation. A values clarification worksheet is a tool where the patient and or the family member can fill out how they would respond in different situations. For example, if they were in a serious car accident and unable to regain consciousness, how important is life-sustaining treatment in that situation? Or if they had a terminal diagnosis of end-stage cancer, how would they feel about life-sustaining treatment at that point in time? It helps you tweeze out certain situations given some specific boundaries. The next step, who should be involved in the conversation? It's helpful to have a facilitator, somebody who's going to be a champion in your clinic or at your facility, who's going to organize, coordinate, and initiate the conversations. Whenever possible, the patient should be involved. So if they have capacity or their capacity waxes and wanes, but they still have the ability to communicate values and wishes, that might be a good time to have them involved. Also, having their medical power of attorney present is important. This is the person who's going to be speaking for them should the patient not be able to, so it's important for them to hear what the patient values. Other family members. Don't forget that with technology, any family member can be easily connected to be a part of this conversation via many platforms such as Zoom or even a telephone call. Sometimes it's important to include spiritual and cultural leaders. We can't separate that part of the person. And if it's an important part of who they are, it would be important to have that person present for their support and understanding. And have a medical provider available so that they can address any of the complex medical questions that may come up during the conversation. Once you have the group gathered, you start off by asking permission to have the goals of care conversation. This is needed for billing purposes and needs to be documented in your note. It's something simple to say, like, today we're going to talk about your recent hospitalizations and any worries or concerns that you had. This will help us put together a plan for the future. Is everybody okay with us proceeding with this conversation? Next, think about the location that you're going to be having your room. Make sure that the room is set up appropriately, that people can see each other, that you have things like water available, Kleenexes, that you give instructions on where the people can go in case they need to use the restroom. Have it quiet, turn your pagers off, make things comfortable for everybody involved in the conversation. Always make sure everybody in the room has a chair. You have to sit down for these conversations. There should never be any doorway discussions. This is not something you stand at the doorway and talk to patients about. This is something you sit down, look them in the eye, and give them time to have a conversation. One format that is often used for advanced care planning conversations is the CARE format. We'll go through the acronym to try to develop some skills to help you have these conversations. The first one is C, clarify. Clarify is the beginning of the conversation. You're going to do introductions of everybody in the room so that everybody understands what each person's role is and why they've been invited to come to this meeting. You also want to build rapport, establish a connection with the patient beyond the medical chart. One of the phrases I like to use is to say, you know, Joe, I've had the chance to read your medical chart and I understand what's happening from that perspective, but I don't know a lot about who you are as a person. Can you tell me a little bit about yourself? I might have to facilitate some of those questions by asking things like, where did you grow up? What kind of background do you have for school? What kind of work have you done? Tell me about your kids. Doing a little bit of a social history with that patient. It's important to do this not only with the patients, but if you're only visiting with the family members, to also get an assessment of who they see their loved one as. Tell me what your mom's strengths are. How do you describe your mom? What's important for me to understand about your mother that I can't read in her chart? Simple phrases like that can help you establish rapport. Once rapport is established, you have a trusting relationship to proceed with your conversation. A is assess. First, you're going to ask and then listen to the patient's perception of their medical situation, as well as their values and goals of care. Some of the phrasing that you could use is, um, tell me what your understanding is of what the doctors have shared with you about your illness. Or, what do you remember the doctors telling you this morning when they came in? This will give you an understanding of what is it the patients heard, will oftentimes highlight what they're worried about. These will be the things that are sticking out to them the most. Um, the third step is R, or respond. So this is an opportunity to provide education to the patient or their surrogate decision maker. So the first time during the assessment, you're really listening to what the patient is saying. Now you're going to respond. And you always want to ask permission before you jump in with your conversation. I will say something like, "Thanks for that information, Joe. I have some more information about your illness. Would it be okay if I shared that with you?" Again, now you're going to have buy-in from that patient to go ahead and provide further education and information to them about their illness and to talk to them about what you're worried about. Another R is reflect. It's an opportunity to summarize what you've heard as part of that shared decision making. I'll oftentimes say, "So, what I've heard you say today is that your faith is important, and that if things were progressing, you would want to make sure that you had your priest available. You would not want to have time in the ICU. You would not want to be on a ventilator. Have I understood our discussion so far? If you need further clarification on something, this is a great opportunity to get that." You might say, "Tell me more about what being a vegetable means to you, Joe." A great time to clarify what they perceive that term vegetable as. The last step is to execute. Once you have had the discussion and you have a summary of what the plan is moving forward, you've identified what their goals are, and you've provided that in a reflective summary, then you're going to document this conversation. And billing requirements require specific things that should be put in the documentation. And then you want to file this in the appropriate location at your clinic, at your facility. So you need to know what your policies are around this documentation. But if you don't document the conversation and what was important to them and what the plan is moving forward, then the advanced care planning conversation goes no further than that room. And the goal is to share those values and wishes with as many people touching that patient as possible. And briefly, I did mention documentation and that there were certain things that needed to be contained in your note for the billing process. By no means do I want to come across as being a billing expert, but you should document in your note who's present, that there is a voluntary nature of the meeting. That's why you ask and say, "Is it okay if we proceed with the conversation?" Because then you can document, "I have provided all in attendance the opportunity to decline to participate in the meeting." You're going to provide a summary of the issues that were discussed. You're going to talk about the patient and the family perceptions of their current illness, the decisions and goals identified, the role that spirituality plays. Is there a role of prior losses, and how do those fit in with their current understanding of what's happening? Assessment of their current symptoms and what you decided for treatment options. Address any advanced directives. So, do they have one? Did you create any new ones as a result of this conversation? And then you're going to document your follow-up and recommendations along with the time spent in the conversation. And that might say something like, "I've spent a total of X number of minutes in the care of this patient, with greater than 50% spent in education and coordination of the patient as detailed above. I spent X number of those minutes on advanced care planning items, including but not limited to living wills, medical power of attorney, code status, quality of life, priorities, hopes, fears, treatment options, disposition location, and service options." When you're billing, you want to use the 99497 code for the first 30 minutes, and 99498 is billed for each additional 30 minutes. This conversation can be held and billed for with the patient or the legal surrogate decision maker. Remember, there's no copay if this conversation is held as part of the annual wellness visit. Otherwise, copays do apply. There is no limit on how often it can be billed. So if you need to have one conversation and a week later a follow-up conversation because the family needed more time to think and discuss, by all means feel free to have them come back and have an additional conversation. Each time there's a change in condition, you should be having a conversation. So there is no limit on how often you can bill for the conversations. It's not limited by the setting or the practice. So these can be done via telehealth. They can be done in the person's nursing home residence. They can be done in your clinic. It must be done by a provider. There is incident to billing available if that is allowed in your clinic. Um, again, the required documentation elements that we've covered, and there's no specific diagnosis required to have the advanced care planning conversation. That can simply be the reason for your meeting. As we mentioned early on, as a byproduct of having an advanced care planning conversation, you may end up creating some paperwork. Oftentimes, the paperwork that will come out of these conversations include a living will, which is a legal document, and there are certain criteria that have to be met in order for the living will to become effective. A durable power of attorney for healthcare is also a legal document, and that actually appoints a surrogate healthcare decision maker. Oftentimes, the document will also allow for a substitute surrogate decision maker in the event that you can't reach the primary surrogate decision maker. And then again, in the state of South Dakota, there are transportable medical orders called Comfort One. These are for the emergency medical personnel only, but that allows the ambulance crew to do everything possible to help care for a patient with the boundaries of no CPR and no intubation. Finally is the MOST document, and in the state of South Dakota, we refer to it as the MOST, a medical order for scope of treatment. In Minnesota, they have POLST, physician order for life-sustaining treatment, and in Iowa, they have IPOST, the Iowa physician order for scope of treatment. These documents are pretty much nationwide with a few exceptions. They're all called similar titles to the MOST or the POST, and each state has different criteria. So you should be familiar with what the state recommendations and guidelines are before you're completing these transportable medical orders. But in the state of South Dakota, it was passed in the South Dakota legislative process in 2019, and it must be part of a shared decision-making conversation with the patient and or their surrogate, along with a medical provider. The provider is a physician, a nurse practitioner, or a physician's assistant. In order to complete a MOST, they must have a terminal diagnosis, and that you wouldn't be surprised if the patient passed away in the next year. To get more information on this document, I would encourage you to go to the SADAHO website at sadaho.org/most. This is where the document is being held to make sure that there are no changes made to the document, and if and when it is ever updated in the legislative process, it can be easily updated in one location. And finally, we're going to end with another scenario to demonstrate the importance of having advanced care planning conversations for patients and their families. So this time we have an 85-year-old female with mild dementia, recently diagnosed with pancreatic cancer with mets to her liver. She had a conversation with her oncologist, and that included a discussion of the natural progression of the course of the illness, her prognosis and treatment options, including hospice care. The risks and benefits of chemo were also discussed and explained that survival with no further therapy is less than 3 months and at best a year with chemotherapy. Surgery and radiation are not an option in this situation. Comfort care was encouraged multiple times, but she wanted to proceed with chemotherapy. She is full code. Her husband was present for the conversation with the physician. She was hospitalized shortly after being admitted to a nursing home after her first round of treatment for weakness, nausea, and is now coming back to your facility for strengthening. What would your next steps be? What would be important to find out? For me, if I were working with this patient and she were coming back to my facility, I'd want to sit down with her and her husband and any other family members and find out what her experience is now that she's had her first round of chemotherapy. Explaining that I had understood she had made this decision to do that. She had made a fully informed decision, but I'd want to know what her understanding was. How did it feel when she was in the hospital? Was chemotherapy what she expected? How does she feel about having more? If she felt this poorly after the first round of chemotherapy, is she worried about how she might feel after her second one? Would that be worse? What would be more important to her at this time in her life? This gives her the opportunity, in a respectful and dignified way, to change her mind, to provide her support and encouragement for doing what she's already done, but opening the door for her to make changes in her treatment plan based on her most recent experience. It also gives time for family members to share their experience with the episode and how they may now have new worries because of her reaction to her chemotherapy. Um, this will give you a much more clear understanding of what to do as she's in your facility, should she have another event, um, or anything else that may come up. It's also a really good time to address her code status again. Having gone through treatment not knowing what to expect and now having an outcome that she wasn't expecting may have changed her mind and her values on what's important. So we always want to give the patient the opportunity to really express what their experiences were like and how that impacts their future care. As always, we want to provide references for you so that you can do your own research and get more information on anything that you found helpful. Again, more references for your own reading pleasure.
Thank you for listening on Advanced Care Planning by Michelle Snyders. This palliative care education is supported by the Health Resource and Services Administration, HRSA, and the U.S. Department of Health and Human Services as part of a grant awarding totaling $900,000. The contents of this presentation do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government.